Yeah, so for the next session, Ivan, can you put the slides of the speaker and also share the screen? Yeah, so we'll have one more session before we go for the tea break. And that's going to be from Patrick Ken Kalambe, quantifying travel time, mapping and validating health facility catchment areas in Blantyre City. So yeah, just waiting for just 1 week for the members of the academic committee to join on Zoom, and then we shall have Patrick's message. Actually, Patrick, I'm also welcome. Please, a round of applause for Patrick as he joined us on the stage, and we are taking it away. Yeah, I think I'll just add that Patrick is a PhD student for public health research group, Malawi Liverpool Welcome Program. So yeah, thank you, Patrick, and over to you.
Thank you very much. I've already been introduced by Geoffrey, so I won't talk much about myself. This morning, I'm going to share about the project that our team in Malawi is implementing. Next slide, please. And I'll share a little bit about the background of the project. So over the past 2 decades, we have seen a decline in cases of malaria. And this comes from the WHO. As you can see, from 2010 to 2015, cases of malaria went down. And for most countries, like for example Malawi, the cases are low, such that malaria cases in the country have now become more heterogeneous. Suffice to say that we have hotspots of malaria that should be targeted interventions. Next slide. And in our research group, there was a project which we were working with Minister of Health. We were trying to identify these hotspots. So these are the districts which we categorize, those ones in red, we categorize that these are the districts which are having a high burden of malaria. But we also understand very well that the way malaria is heterogeneous, the spatial burdens of malaria has to be quantified at much more fine scale. So we were doing a project where we wanted to move low the level of the larger administrative unit to actually identify specific facilities that are having more cases of malaria. Next, please. And this map on the left side, my left side, is actually highlighting what we are doing to actually trying to identify facilities that are reporting a lot of cases of malaria. And as you can see there, you can see that some of the districts, there are a lot of variation. Some facilities having a lot of cases and some few cases. Next. But cases alone cannot help us to understand the burden of the disease. So we can get what we call disease distinct. So which is actually total number of cases divided by the population in that particular unit of interest. But where can we get this data on population? We know that there are a lot of population estimates from, for example, we have data from NADA, which one can use to extract human population data to calculate prevalence of a disease. Next. And next. And what we did in our team, for us to calculate the population, we had to generate catchment areas of facilities using an approach that was developed by the Malaria Atlas Project. And what we observed was that when you come to generating these catchment areas, when you are actually trying to generate them for a location with high density of facilities, for example, in cities, there was a problem. Next, you see that there is a catchment area with 2 facilities in the catchment area. And next, please. So the reason why we had that challenge is because they say garbage in, garbage out. We were using a 1 square kilometer friction cost surface that was helping us to compute these catchment areas. And at the scale of 1 square kilometers, in a location where you have a high density of facilities, for example, in the cities, you have problems like the one that we showed you in the previous slide. So, regardless of the challenge that we observed, we noticed that trying to compare these catchment areas with location data for malaria visits, we noticed that there was correspondence of about 82.2%, like 82.2% of people were coming from these catchment areas with problems. And despite that 82.2 might seem like a good figure, there was some variations. Some facilities, like out of the three, some facilities, the performance was just too low. For example, there was one facility about 56% correspondence. And because we knew that this overgeneralization was coming from, this problem was coming from overgeneralization, which is coming from the patient code surface. What we did, we decided to develop our own patient code surface for Blantyre and eventually develop the catchment areas of Blantyre. Next. Yeah, so that's just to highlight the friction code surface. It's one kilometer, and in some locations, for example, informal settlements, you have a lot of people in small space. So, like that's just 1 pixel, 1 square kilometer, and that's a big neighborhood. This neighborhood that you are seeing on the screen has close to, I think, 12% of the population of the whole city of Blantyre, but there's just a few pixels. Next slide. So the objectives of our work was actually to explore an optimal approach for marking catchment areas in a setting with high density of facilities. Next. First, I'll talk about what we did, trying to identify existing catchment areas in Malawi, because we know that we're not the first one to think about this problem. But we also wanted to understand the current practices which have been employed in health facilities. Next. And beyond that, we now wanted to update the road network for Blantyre because we know that when people access services, they use the road to go to the facility. And lastly, we want now to generate and validate the catchment areas for Blantyre. Next. So, what we noticed. So, what we noticed is that in Malawi, we have catchment areas for facilities. And these catchment areas were developed in the early 2000s by the Malawi government under what they were calling the Health Management Information System. But we have a lot of facilities, but with this catchment which exist, we only have about 522 facilities in catchment areas. Because between the early 2000s and now, a lot has happened. So we know, and even the Ministry of Health acknowledge that these catchment areas are out of date and they have to be updated. And we also noticed that in health facilities that we visited, health surveillance assistants are actually exploring alternative ways of controlling their own catchment areas to aid their planning work. Next. For example, this is a map that we found in one of the facilities. It's a catchment area for Blantyre Center. And what they normally do, the health surveillance assistants, they will sit down with a paper and they will draw the catchment area of the facility. And they divide work amongst themselves using these kinds of catchment areas. Next. So, for us to improve these catchment areas, we use an approach which was developed by a team from Geneva. It's called Access Model. Next. So, what is a very simple algorithm to use several tools within the open mapping community. For example, there's a list called algorithm. It's also available within QGIS. So, what you need to implement this approach, you just need to have locations of facilities as points. You just need to have information like, for example, roads. You can have land cover map, and you can even have the topographical data for your area of interest. If you have all those data sets, it's just a click of the button to generate catchment areas. So the algorithm is very clever, as you can see on this slide. It can actually be able to, because it calculates the cost to go to the facility. What it does, it tries to avoid maybe using maybe a mountain, maybe crossing a river. It maximizes using the road to go to the facility. So that's how it works in simple terms. Next. Yeah, so as I mentioned, we needed roads data for Blantyre City study. But what we noticed after looking at the satellite imagery, the master imagery for Blantyre City, we saw that most of the roads were not mapped. Some roads were mapped, but we saw that a lot of roads were not mapped. So we used the humanitarian agency map task manager to actually organize the mapping, several mapping activities. Actually, I should say, to organize a project where people, the world, helped us to map the roads in our city. Next. So we also organized two mapping events, physical ones. This is an event that we organized at our research institution. We had university students from the Youth Mappers chapter at the Malawi University of Business and Applied Sciences. They came to help us mapping some of the roads. Next. Next. Of course, beyond this, next, we also engaged staff members from our research institution. These are people who have never done any mapping. Some of them are veterinary doctors, some of them are statisticians, some of them are even economists. So we had to introduce them to the map, and they helped us to map a few roads in Blantyre City. Next. Next. Yeah. And beyond mapping the roads, because at this point in time, I assume that you know that now we have mapped all the roads. Now we wanted to establish, because when the people are going to the facilities, yes, they will use the road, but they walk at a particular speed. So we wanted to establish the travel speed that people are likely to yeah. So we identified 5 residential communities. We identified these randomly, and we went to these communities to observe how fast people walk across a distance that we know. Next. Yeah, next. Yeah, for example, this is one member of our team making those observations. So, next. What he was doing, he would mark the distance to say that from that end to the other end is maybe 20 meters. So he was calculating with this phone in his hand, seeing how many seconds does it take for someone to pass that stretch. Knowing the distance, and because we measure that one, and also knowing the time, it is very easy for one to calculate speed, because we know from primary school mathematics that speed is just a function of distance and time. Next. So all the roads that we were making observations, we also had to extract the relevant OpenStreetMap highway tag. So suffice to say that we're able to compute average travel speeds for different roads that we mapped Blantyre. Next. And these are the summaries of the travel speeds that we observed. Next. So with the travel speeds, it is now easy to compute the travel time from each and every location in Blantyre City to the nearest facility. So we computed the travel time, because we know that for you to calculate time, you already know the speed. It's very easy. You just make time to be the subject of the formula. So with that being said, we were able to compute the time, as you can see in that map. Some of you might be wondering, why are we having, because that black line, that's the boundary of Blantyre City. Why are we having facilities outside Blantyre City? We knew that facilities outside the city can have an influence, because people can go to a nearest facility despite whether or not it's in the city or not. So we have to include a buffer of 10 kilometers. So all facilities within the 10 kilometers buffer of Blantyre City were included in our analysis to account for the effect of people going to a facility nearest one but outside the city. So yeah, next. So what we did basically, we moved from the use of the Malaria Atlas Project catchment areas, which look like this, to having catchment areas that look like the next slide, this. So these are the catchment areas that we're able to generate. On my right side, we have catchment areas for public health facilities, and to my left, those are catchment areas for private facilities. And you can see clearly, I don't know where my slides have gone to, but you can see clearly from where I was pointing out that 2 facilities were just within one catchment areas. Now you have those catchment areas, each with its own catchment area, somewhere there around the middle. I think some people can notice that. Next. Next. Yeah. So in terms of now validation of these catchment areas, next also, we identified 3 facilities. We went to these facilities. These are the ones that we observed in the practices in terms of how they're mapping the catchment areas. So we went to these facilities, we digitized malaria records. So when you observe yourself at the hospital, test for a malaria test, they record where you're coming from. So we had to digitize all those records, and we had to summarize the locations where people are coming from and visit those locations because we did not have data for village locations. So we had to map those locations on our own. Now, with this information, we're able now to see whether or not these point locations where people are coming from are indeed falling within our areas. So what we found is what you can see now on my left side. We saw that in most of these facilities, a lot of people are coming from our catchment areas. And on average, we saw that about 94.5% were coming from our catchment areas. Next, please.
Recording in progress.
Yeah, and some people may be wondering, what value have we added to this? So what we're seeing there, this is the performance of using, so those are the 3 facilities that I was talking about. And in the middle, that's the, if we try to use the existing catchment areas for those 3 facilities, because those ones we already had facility catchment areas from the information project that I was talking about from the early 2000s. So when you use those catchment areas, we notice that for these 3 facilities, our point locations for malaria data, there was a huge correspondence, like about 97.4%. But mind you, this is just for 522 facilities, not all the facilities in the country. The performance is very, very good. And if one is now to use the catchment areas generated using the Malaria Atlas Project friction point surface, the performance is around 82.2% on average. With some facility, like for example, in one 99.5%, very good performance. But look at Nilande Center. I mean, look at Blantyre Center. It's about 56.3%. Next. Oh, yeah, that one. Now, to my far left, those are the catchment areas that we generate. You can see that, yes, the performance is much more lower than the one that were the catchment areas that were generated in the early 2000s, but it's far much more better than using the Malaria Atlas Project. You can see that for all the 3 facilities, the performance is over 90%. Next. So people might be wondering, what's the next step? So we have seen that the catchment areas that we have developed, they have got huge potential to be used as facility catchment areas, especially they can be used for estimation of human population surrounding these facilities. And this can help us to quantify the burden. And what's our next step? Our next step is actually to explore sensitivity of people who are seeking healthcare, the choice of, because in this way, we're just assuming that people choose the nearest facility. But we have read papers, for example, I read a paper from Zambia where they said that if someone wants to go for HIV testing, people might choose to go to a facility that is actually far, far away from their homes. So we would like to conduct a discrete choice experiment to explore how sensitive is the choice of health facility to this kind of variables. For example, nearness, the disease, and even the capacity of the facility. And we also intend to build on this project to improve catchment area mapping in facilities. Remember, I showed you a picture of how people are mapping catchment areas in facilities. So we'd like to build on this project to improve the current practices in these facilities. And we would like particularly to work closely with health surveillance assistants to actually improve their work. And we also hope that maybe from this platform, we can explore opportunities to scale this kind of work to other countries because this is a method that already exists. Next. And this work was not done by one person. There's actually an African proverb that says, if you want to go fast, go alone. But if you want to go far, go with others. Let's go together. So this project was done by a team. That's what you mentioned, the existence of informal geographical team at my institution, my supervisors, my PhD supervisors, and hundreds of volunteers from the open learning community who helped us map all these roads. Taking this far end, let me say thank you very much.
I can just put it in. Yeah, Victor, any comments? Anyone with questions from the room? Okay.
Yeah, thank you for your presentation. So my question is, you mentioned you were measuring the distance of people walking. So I wanted to ask, like, was it distance of people walking to hospitals or people just going to different places?
Yeah, thanks so much. One of the major limitations of our work is actually that we were just observing people walking. It was difficult for us to actually isolate to say that we need just to be observing people who are going to the hospital. It was very challenging to observe that. Other studies, similar studies to this one, there's a study from the actual numerous papers published by someone from Kenya, Peter Majali. They have been recently using data from Google. So Google collects data in terms of speeds. So they were using the Google API sort of, and that's an alternative way. But even with that approach, yes, they have a big sample size, but these people are not even going to the hospital. So if one can meet our preprint, we have highlighted that challenge also.
Thanks for the wonderful presentation. My question is, is the work mainly on road? As in, I don't really understand the work. Is it on road, people trekking to the hospitals to receive treatment? That's what I'm about.
Yeah, so we assume that the people that we're observing, we assume that the travel speed that we observed, they are similar to the ones like they will be similar to people who are going to the facility treatment.
So that is DODs or settlement we are not concluded in the work in the session. If you have said we have done some analysis on maybe using fish network or buffers to see the distance people trek to the facility to receive treatment. Then from your findings, be able to give send information to the appropriate quarter that there is need for more facility help to be cited because of the distance people trek or walk to receive treatment.
Yeah, thanks so much for the question. Related to the last part of your question, I think if you remember, I highlighted a map on travel time to the facilities. If maybe if the government entity would like such kind of information, identify where they should then put additional facilities. They want just very simple with that approach. They will just identify locations where people like from that unit they travel more, like the time is just like substantially larger compared to other facilities. But we can have a separate conversation more on that.
Okay, first I want to congratulate you for the huge work you have been doing. And on top of that, I have one, I want to share something and also to add a question on what you've been presenting. So, for example, in Tanzania, we had kind of the same initiatives whereby the main aim was to identify catchment areas. And one of the things we've been doing is community mapping. So, community survey to identify people where, for example, for this treatment, where hospital are you going? And also, another intervention we just did was to use the registration proper registration system in the hospital. So we did in one of the hospital whereby we created a dashboard, and on that dashboard, you mentioned one challenge whereby in your place there's no a good village data. So, for example, in Tanzania we have all registration data which are proper, but also we had another layer which was not existing, which is hyper local boundary. So when someone go to the hospital, you register from the region, municipal, ward, street, and hyperlocal boundary. So at the end of the maybe a day or week, the hospital can do analysis and see which case come from which area. So that which is very simple, it can be updated as the things going on. So coming to the question, from the community survey we've been doing to identify which people going to which hospital, we identify that there are some issues which happen because of some social factors. So you can find that someone is living near the hospital, but he's not going to that hospital to get service because of some of the cases, like some of the hospital experience. Also, some of the people are going to other hospital because of reference from the employee that the certain of hospital they are giving good service. So we have a lot of social factors which led people to go to hospital which it's not, they are not in that catchment area of that hospital. So how are you taking care of those kind of issues? Thank you.
Thank you very much. Looking at the correspondence of the catchment areas of malaria data, we saw an average of over 94%. It's good. But we, as I mentioned previously, some diseases, it might be too sensitive, like people cannot go to the nearest facility. But the question which we should be asking ourselves is like, how big of a problem is, how big of a problem is the influence of these other factors? Because, for example, in malaria, we found that the 4% yes, data come from the country. 6%, 5.6% are coming from outside, that coming from outside the country area. Why? Maybe because someone fell sick when maybe the person was at work, or other reasons that we don't understand. That is why we have found it compelling to conduct a street choice experiment to understand better about these complexities. So I think maybe the next set of map will be able to update this audience about the progress that our team will make. I've just been told that my time has been exhausted. So I think we'll continue the conversations in the table.
Yeah, thank you so much, Patrick. Yeah, I would have loved to get comments from Victor and the people on Zoom, but I'll try to see how we can fix that. So, yeah, we're going for the tea break, but I just have an announcement. Yes, on day one, we had a panel discussion in the main room here, which we shifted because, yeah, we were late to the program. We're trying to catch up with the program. So that session has been replaced. I mean, it's happening today. But let me just give 1 minute to Innocent, just tell you where that session is going to be happening and what the panel discussion is about so that you can join it when you want to.
Thank you, Geoffrey. Good morning, everyone. Good morning, everyone. You guys are tired. Are you tired? Like, it's been 3 days and so I had a session, like it was supposed to be the first, but because we were